Good evening, everyone, and welcome to today's wonderful evening with Dr. Murali Bharadwaj on the mock test 17, NEETPG mock test 17 live discussion. Please inform all your friends that the teacher and the students, we're all online and we are going to crack the test 17. So before coming to the mock test, it's wonderful evening with Dr. Murali. So always my advice to the students is take the question paper, solve it, whatever be your marks. After solving, go to the learnograph.com, download the PDF. In that you have 200 questions, explanatory answers. Try to sit with 2-3 friends, discuss the explanatory answers, what were your answers, everything you can do because the ebook is in your laptop, right? So good to see Dr. Ravinder and many more who are all online. So let's make the great beginning, Doctor. Akash Kumar Rai says, suddenly I found your video, sir. After so long, still love your voice. I have joined AIMS Partner as senior resident and have learned and got selected in the NEETPG in general medicine. Really proud to know this, Dr. Akash. I will always relish the good compliment and the good words by wonderful students like you. General medicine is called the emperor, right? So once you are general medicine throughout life, you are the one who will dictate the terms of what subspecialists forget, right? So that should always be the spirit. So in the past so many years, 25 years, 3 lakh medical students, lot of them became toppers who are mentored by me. So every time they all started in a small way with a lot of uncertainty, what is going to be the outcome of the PG entrance, but ultimately they made it all. So first believe in yourself, do a little effort for 5 to 6 hours in a very focused manner. Automatically you will win the NEET-PG exam. So let's make the great beginning, Doctor. With that preamble, good to see almost 8 online classmates. Can you please punch? Is the voice loud and clear for all of you, Doctor? Yes. A patient reports a sudden loss of vision in one eye. Fundoscopic examination is being shown to you. So sudden painless loss of vision with extensive retinal hemorrhages is very characteristic of central retinal vein occlusion. CRVO is what you need to remember. Right? Thank you, Ravinder, for the feedback. Loud and clear. A patient presents with a red, painful eye, decreased vision. Fluorescein examination is showing a branching corneal ulcer, which is staining with fluorescein, is characteristic of herpes simplex virus keratitis, is what you have to basically remember. A patient presents with a sudden deterioration of the central vision. Fundoscopy has been shown to you. So what is this called? Sudden loss of central vision along with macular edema, subretinal hemorrhages on fundoscopy typically indicate wet age-related macular degeneration. Age-related macular degeneration, ARMD. There are 2 varieties. One is called the wet variety, other is called dry variety. This is a wet variety of ARMD. So everything, anything about the age-related macular degeneration has been presented, doctor. So how do you treat the age-related macular degeneration? Intravitreal injections. Oh, I'm sorry. Yeah. Sorry. Yes. Okay. MCQs are now seen. Sorry about that. I'll quickly go back to what we are discussing. So this is how you are able to see the wet age-related macular degeneration. Age-related macular degeneration. Okay. Now I think the screen is visible. Yes. Yeah. So intravitreal injection of the anti-VEGF medications are the primary way to stop the wet age-related macular degeneration. The earlier question was about the fluorescein examination of a red painful eye lesion, which is classically the herpes simplex virus keratitis with a dendritic ulcer. And the first question was multiple retinal hemorrhages in a patient with a sudden loss of vision. This is characteristic of the central retinal vein occlusion is what you have to remember. So, doctor, let's go to the next question. A patient presents with a sudden loss of vision, one eye, pain with eye movement, very important. Painless vision loss, painful vision loss, you should know the differences. So a fundoscopy examination has been shown to you. Now the question is, what is the most likely diagnosis? Acute optic neuritis is a painful loss of the vision is what you have to basically remember. It's an inflammatory demyelinating disorder of the optic nerve, often associated with multiple sclerosis. It typically presents the rapid onset of the vision loss, and pain on the eye movement is very, very classical in case of acute optic neuritis. A patient reports gradual worsening of the vision over several years, significant glare at night, and difficulty reading small print even with glasses. So what is your diagnosis, doctor? It is a classical example of a cataract. So whenever there is any gradual loss of vision, right, doctor? Gradual loss of vision, right? Yes. With significant glare at night. So what you are seeing here is a cataract is what you need to remember. So seeing halos around the lights, sensitivity of the light and glare, frequent changes in the eyeglasses, right? And these are all the ones which are associated with cataract clinical presentation. A patient presents with a high stepping gait as what you can see here. High stepping gait with a notable foot slap at the end of each step. So this is classical of a foot drop which occurs because of any injury to sciatic nerve, peroneal nerve. So lower motor neuron lesion typically lead to the foot drop is what you need to remember. A patient with pruritic violaceous lesions on the wrists and shins, right? Upon examination of flashlight, you will see small initial lesions are noted to reflect light-like stars. So what is your diagnosis? This is classical of lichen planus. Remember, pruritic, polygonal, violaceous lesions along the typically which shine like shine by reflecting the light is very characteristic of lichen planus. They are flat-topped, shiny papules that resemble stars under the direct light is what you need to remember, right? So that is lichen planus. A patient after falling on an outstretched hand, push, it's called, falling on outstretched hand, foosh, F-O-O-S-H. Typically is presenting with a dinner fork deformity, which is characteristic of coleus. Patient has a difficulty seeing at night, noticeable loss in peripheral vision, bony spicule appearance on the retina, which is all characteristic of retinitis pigmentosa, is what you have to remember. A patient with a double vision and clinical examination is being shown to you. So, inability to abduct the eye, which is making the eye to move inward, right, is very characteristic of sixth nerve palsy, is what you have to remember. A patient exhibits a gait which is unsteady, wide-based. It is very unsteady. He is oozing, right? And what type of ataxia could this be? This is cerebellar ataxia. Unsteady, wide-based gait with exaggerated foot motion, with a heavy heel strike, is indicative of cerebellar ataxia, is what you have to basically remember. Now, doctor, a patient presents with bone pain and an X-ray is being shown. Unsteady gait, relies heavily on visual clues to maintain balance, right? So you are able to see bone pain, lytic lesions, and a gait which is dependent upon the visual clues. It is all suggestive of multiple myeloma leading to neuropathy, leading to sensory ataxia, is what you have to remember. A patient presents with recurrent UTI, CT scan is being shown to you. So there is a pneumaturia also in this patient. There is a CT finding of air within the bladder, right? CT finding of air within the bladder. So it is a colovesical fistula, which can occur as a complication of the diverticulitis. Diverticulosis is what you have to remember. Now, a patient presents with non-specific GIT symptoms. Endoscopic examination is being shown to you. So, submucosal tumor, what you can see here, submucosal tumor, you can see submucosal tumor along the lesser curvature of the esophagogastric junction, and which is low echoic, abnormally enhancing mass. It suggests GIST, which is gastrointestinal stromal tumor, is what you need to basically remember. So once more, anything about GIST tumors, doctor, c-KIT mutations, everything you should know. Now, a patient has a history of chronic gastritis, and a gastric lesion was found on endoscopy. The biopsy is showing a lot of lymphocytes. So it is an example of a gastric mucosal associated lymphoid tissue, maltoma. It is a tumor of the mucosa associated lymphoid tissueoma, is what you have to remember. Now, a 48-year-old presents with epigastric pain, signs of protein losing enteropathy, and the stomach has thick rugal folds, which is called Mentrier's disease, right? Mentrier's. So he has got large gastric folds combined with protein losing enteropathy, hypochlorohydria. They're all characteristic of Mentrier's disease, is what you need to remember. Now, doctor, a 25-year-old comes for routine checkup. They have a family history of familial adenomatous polyposis and undergo sigmoidoscopy. And the endoscopic image of the sigmoidoscopy has been shown to you. So what are these? Tubular adenomas, which typically develop in a patient who has got familial adenomatous polyposis, is what you need to basically remember. During an elective abdominal surgery, a small pouch, as what you can see, is being identified 15 centimeters from the ileocecal valve, which is very characteristic of Meckel's diverticulum, is what you should remember. Infant with abdominal distension, erythema around the umbilicus is what you are able to see. Erythema around umbilicus. There is a lot of the gas within the intestinal wall, and there is a necrosis which is characteristic of necrotizing enterocolitis is the diagnosis, is what you need to remember. Now, a 63-year-old with history of atrial fibrillation presents with severe abdominal pain, right? So you are able to see the image. So typically the abdominal pain is more on eating food, which is very characteristic of abdominal angina, it is called as, which is seen in the case of mesenteric ischemia. So here you need to do the surgical revascularization of the mesenteric ischemia. 57-year-old with severe abdominal pain, one more classical case, is an example of acute mesenteric ischemia, is what you should remember. Then 57-year-old with atherosclerotic heart disease with acute abdominal pain, and when you have done the mesenteric angiogram, you are able to see an occlusion, which is very classical of, once more, the acute mesenteric ischemia, and you need to do intra-arterial thrombolytic therapy to break the mesenteric thrombus, is what you need to remember. A 38-year-old with abdominal pain and diarrhea, CT imaging has been done. So it is also another classical example where you are able to see the acute mesenteric ischemia, which require immediate surgical resection. Venous acute mesenteric ischemia is what you have to remember. A 67-year-old with a vague abdominal pain, you are able to see the mass here. So mesenteric mass is there, encasing the superior mesenteric artery branches and causing the vascular complications, which is very minimal bowel involvement is there, which is very characteristic of ileal neuroendocrine tumor like a carcinoid, is what you need to keep in mind. A patient has a lower abdominal pain, cervical speculum examination is being shown to you. So this is an example of a pelvic inflammatory disease, and you need to start her on empirical antibiotic treatment is the treatment of choice. A 72-year-old with a lesion shown, biopsy is saying a moderately well-differentiated squamous cell carcinoma. What is the immediate concern? So typically it is cervical cancer treatment in the form of radiotherapy, etc., need to be implemented. So that is all the story of the image-based questions, doctor. Now, there are some more image-based questions. Sorry, the question is missing here. A patient presents with several clear fluid-filled blisters on the neck and back that rupture easily. They are flaccid. There are also painful erosions. It is actually pemphigus vulgaris. The image is missing, but it is there in the question paper. Kindly check that. A patient with known liver abnormalities presents with the tremors and speech difficulties, right? So this is what, can you see the Kung Fu Panda? This is called the Panda sign. So Panda sign is a very important indicator of Wilson's disease. Can you appreciate, doctor? Wilson's disease, where you can see the Panda sign, which is very classical of Wilson's disease, radiologically. A 78-year-old man with a non-healing ulcer of the glans penis that persisted for 3 months and foul-smelling discharge. So it is a squamous cell carcinoma of the penis. So that is what you need to remember. Now, doctor, which drug used in the treatment of hairy cell leukemia has the primary mechanism shown in the figure? So let us look at where is the drug. The drug is inhibiting adenosine deaminase, leading to accumulation of the adenosine that in turn will cause a ribonucleotide reductase inhibition that blocks the DNA synthesis. It also leads to S-adenosyl homocysteine accumulation, which is toxic to the lymphocytes. Which is that cancer drug, doctor? It is typically in hairy cell leukemia. It is the pentostatin is the correct answer, which inhibits the enzyme adenosine deaminase, which is very critical for the metabolism of the purines, is what you need to remember. A 48-year-old with cirrhosis presents with abdominal pain and fever. Abdominal radiograph and the follow-up radiograph has been shown to you. So typically you are able to see the ascites, and subsequently there are pulmonary changes, as what you can see here, right? So it is strongly suggestive of spontaneous bacterial peritonitis, where there is an infection in ascitic fluid whenever there is any severe liver disease, is what you need to remember. So whenever ascites with spontaneous bacterial peritonitis is there, peritoneum is very tender. It won't let the abdominal movements to be free, and that leads to the development of atelectasis, which is typically seen in the follow-up radiograph, is what you need to remember. A newborn with a rash, which is being shown here, a newborn with a rash consisting of purplish spots, including jaundice and hepatosplenomegaly. So this is a case of congenital cytomegalovirus infection, is what you need to basically remember, right? So it's called blueberry muffin rash is the characteristic name. A 4-month-old infant is being brought to the pediatrician. What do you see? Periventricular calcifications are formed. What is that starch group of infections which lead to this? It is the cytomegalovirus. Congenital infection will present with microcephaly, auditory loss, hepatosplenomegaly, intracranial calcifications which are in periventricular distribution is characteristic of cytomegalovirus. Now, a newborn male is evaluated, poor feeding, decreased fetal movements during 3rd trimester. There is a continuous murmur in the left upper sternal quadrant. Chest radiograph has been shown to you, right? So what do you see radiologically, doctor? So you look at the size and shape of the heart and how is the pulmonary blood flow, right? So there is a cardiomegaly in case of total anomalous pulmonary venous circulation. And there is a pulmonary vascular congestion suggesting that there is an increased blood flow on the right side of the heart. So this is very, very suggestive of TAPVC, total anomalous pulmonary venous circulation, is what you have to basically remember. That means normally pulmonary veins are supposed to drain into the left side of the heart, left atrium. But if the left and right pulmonary veins combine to form a common pulmonary vein and drain directly into right atrium already is receiving SVC and IVC. So too much blood is entering into the right side of the heart, which is very, very much responsible for the cardiomegaly, is what you need to remember. A 30-year-old woman actually there was a picture of the pigmentation periorally. So hematomatous polyps with intussusception, mucocutaneous pigmentation. You need to think about Peutz-Jeghers syndrome. Now, a patient is having a new onset erectile pain and curvature. That's what you are able to see. Erectile pain and curvature. So, what is this condition which lead to this? It's called Peyronie's disease, where there is a palpable block in the shaft of the penis is what you are able to basically see in Peyronie's disease is what you need to remember. Now, a 30-year-old male is performing this test, right? And there is a tingling in the thumb index and middle. So this is characteristic of carpal tunnel syndrome. What is this maneuver called? Phalen's maneuver is the maneuver which you are able to see over here. Then, a 44-year-old male with a history of MEN1 presents with hypoglycemia. Imaging of the pancreas has been shown. So what do you see in pancreatitis? Pancreatitis, see in the case of the MEN1 syndrome, we see insulinomas in the MEN1 syndrome. So MEN1, MEN2A, 2B, you need to be 100% sure. Similarly, polyglandular autoimmune disorder type 1, type 2 is a favorite question of the examiner doctor. A patient presents with severe peptic ulcer disease with refractory gastroesophageal reflux disease. Imaging of the pancreas has been shown to you. So what is your diagnosis, doctor? Gastrinoma typically is the feature which you see in Zollinger-Ellison syndrome. So where do gastrinomas of Zollinger-Ellison occur? They occur in the pancreas. So any refractory peptic ulcer should make you think the possibility of Zollinger-Ellison syndrome. So what is this histopathological feature of the yolk sac tumors under high magnification? So basically, they are called in the yolk sac tumors Schiller dual bodies is a structure which resembles glomerulus in yolk sac tumor is what you should understand. So that brings us to the end of the image-based questions, doctor. Now, let's quickly run through the remaining clinical minute-based 160 questions. IVC is a large vein, and it is the supracardinal, subcardinal, vitelline vein. They all contribute to the formation of the inferior vena cava. So metanephros typically gives rise to permanent kidney. Metanephros. The facial nerve typically is derived from second branchial arch. All branchial arches, what is their nerves, what are the muscles, everything you need to be sure on those derivatives. It is a prophase one of the meiosis. The chromosomes condense and homologous chromosomes pair in a process known as synapsis, which occur during the leptotene and zygotine stages is what you need to remember. Pelvic kidney occurs whenever the kidneys fail to ascend to their normal position in the abdomen and they remain low in the pelvis. Pelvic kidney is due to fusion of the lower poles and it is being blocked by the branches of the aorta. Inability to ascend during the fetal life is the underlying cause. Right, doctor? Now, the next question. Cryptomagna, which is also called intratonsillar cleft. It is the largest of the tonsillar clefts and is a remnant of the second pharyngeal pouch is what you should remember. So what is a traction epiphysis? It is the region of the bone growth influenced by the pull of the muscles. Mastoid procedure traction epiphysis is what you should remember. The liver lobules are classically described as hexagonal, not pentagonal. Herring's canals. I try to run a little fast in these remaining 160 questions because if you already solve the question paper, it is very easy. They are the part of the liver's microscopic bile duct system, Herring's canals. Herring's bodies are the neurosecretory granules which are found in the partial pituitary, which is also called neurohypophysis. The thymus originates from the third pharyngeal pouch is what you should remember. Orbach's plexus is also called myenteric plexus, is present throughout the GIT, including esophagus, stomach, and colon. And all the motor functions of the GIT, like peristalsis, sphincteric contractions, everything is controlled by the Orbach's plexus, is what you need to understand. Esophagus is very unique in the GIT if you compare with any other part of the GIT, because esophagus doesn't have the serosa. That's the reason any esophageal tumor can easily spread across the mediastinum, unlike the remaining part of the gut. The most abundant type of the cartilage is hyaline cartilage. Hyaline cartilage. Hostrations are the sac-like pouches, which are very characteristic of the colon. Colon also has appendices epiploicae, which are not found in other parts of the GIT. The alveoli of the lacrimal gland, they are lined with the pyramidal cells, which are specialized in producing the secretions. The medial two lumbricals of the hand are classified as bipennate, allowing for a greater power in the flexion of the finger, is what you need to remember. Ansa nephroni is a part of the loop of the Henle, is lined by squamous epithelium. It facilitates the diffusion and osmosis. The number of visible carpal bones on the X-rays corresponds to the child's age in years between 2 and 6 years. If there are 4 carpal bones, that indicate 4 years of age, is what you need to remember. The spine of the scapula is a landmark that aligns with the T3 and T4 vertebra on the thoracic spine. I'm running very fast because all these are very factual questions. They don't need a lot of discussion. The deltoid muscle, mainly for the abduction of the shoulder from 15 degrees to 90 degrees, where the supraspinatus is needed for the first 15 degrees. Right? So these funda you should remember. Then flexor pollicis brevis. What is the nerve supply duct? It is innervated by both the median and also the ulnar nerves, is the speciality of flexor pollicis brevis. Wartenberg sign is identified by the inability to adduct the small finger towards the ring finger. It is suggestive of a palmar interosseous muscle injury which occurs whenever there is any ulnar nerve pathology. You see, Wartenberg sign is what you should remember. The ulnar nerve, it provides the sensation at the tip of the little finger. It is the ulnar nerve. The median nerve innervates the palmar side of the index finger, including its pulp, is what you should remember. The radial nerve innervates extensor muscles of the wrist and fingers. Infraspinatus is a part of rotator cuff and it assists in lateral rotation of the arm, is what you should remember. So because the repetitive use, infraspinatus is part of the rotator cuff and that can lead to development of pain on repetitive use in the athletes like the bowlers. So 34-year-old complaining of numbness and tingling in her thumb, index, and middle fingers, particularly in the night, you will think of carpal tunnel syndrome, which is typically seen with median nerve injury. 22-year-old baseball pitcher. It is the coracoacromial ligament that limits the superior translation movement of the humerus in an upward direction. Any thickening of the coracoacromial ligament can lead to the impingement syndrome that presents with pain during the overhead activity is what you have to basically remember. Then coracohumeral ligament, it provides stability to prevent the antero-inferior displacement of the humerus. It is the anconius that assists the elbow extension, particularly during forceful movements like serving in the tennis. It is the anconius. For climbing movements, including adduction and internal rotation of the shoulder, we require latissimus dorsi. It is the posterior interosseous artery which supplies the posterior compartment of the forearm. And this compartment is mainly involved in supination and extension movements is what you should remember. It is the subclavius muscle which is positioned to cushion and protect the brachial plexus and the subclavian vessels from getting injured is what you need to remember. The deep palmar arch is mainly supplied by which artery? It is not ulnar. It is the radial artery is what you need to remember. Of course, it is completed by the deep branch of ulnar artery, but it is not visualized in angiogram. A 22-year-old rock climber presents with the shoulder injury after a fall. After a fall, physician palpates a bony prominence just inferior to clavicle. So what is he palpating? It is the coracoid process that can be palpated just below the clavicle is what you have to remember. An orthopedic surgeon is talking about the rehabilitation. So it is flexor carpi radialis, which inserts into the base of the second and third metacarpals and responsible for pronating the forearm and assisting the elbow flexion is what you need to remember. Iliotibial tract, it attaches to the lateral condyle of the tibia, right? Now, a 26-year-old, difficulty walking on her heels, recurrent tripping after ascending stage. She has a sharp shooting pain radiating from her low back. It is all suggestive of L5 radiculopathy because L5 nerve root is the one which supplies extensor hallucis longus, which extends the big toe is what you should remember. So how do you identify plantar fasciitis? Whenever there is a pain at the heel, which improves on toe dorsiflexion, that is indicative of plantar fasciitis is what you need to remember. Now, a 32-year-old marathon runner comes to clinic with pain and swelling around the lateral aspect of the right ankle. So the location of the pain and swelling corresponds to the path of the peroneus longus tendon is what you need to remember. Any weakness in the dorsiflexion and the inversion of the foot indicate a deficit in tibialis anterior muscle function. And what is the nerve supply of tibialis anterior, doctor? Deep peroneal nerve is the one which supplies the tibialis anterior is what you need to remember. Now, any muscle hypertrophy adjacent to sacrum is indicative of multifidus lumborum, which is responsible for stabilizing the spine during the movements like swinging in the golf is what you need to remember. The sacral hiatus is used as an entry point whenever you are doing a needle placement in the epidural procedure. So S5 nerve root is the structure that passes through the sacral hiatus. The numbness and tingling which is there in the medial aspect of the lower leg and the medial border of the foot after varicose vein surgery means it is the saphenous nerve. Saphenous nerve runs with the great saphenous vein, which is commonly targeted in varicose vein surgeries. The oblique popliteal ligament is an expansion of which muscle, which tendon? Semimembranous tendon. The lateral border of the foot is innervated by sural nerve, which can be irritated or compressed during repetitive motion like running, is what you need to understand. Now, yes, emphysema typically affects the respiratory bronchioles and alveolar ducts, which are derived from the terminal bronchioles, is what you need to remember. The primary bifurcation of the trachea, what do you get? Primary bronchi, which is the next segment in the bronchial tree. The cricopharyngeal sphincter, otherwise called upper esophageal sphincter. Where is it located, doctor? It is 15 centimeters from the central incisor. The arch of hyoid crosses the esophagus at which level? T4 level. Approximately 22.5 centimeters from the incisor teeth, and it can cause a normal physiological impression, is what you should remember. The thoracic duct, it drains all the lymph into the systemic circulation. At which point? At the venous junction, which is the junction between left internal jugular and left subclavian vein, is what you need to remember. So, doctor, so today's test is more or less like an anatomy subject test, more than a full-scale grand test. So we'll try to conduct tests more like a full-scale grand test. So test number 18, tomorrow we will take up the discussion. So every full-scale mock test, take opportunity to solve before you come to class. Then you will enjoy the class a lot. So thank you very much. Read. That's the only option. And you still have a wonderful time. Almost you have 4 weeks of time, 4 to 5 weeks of time is there. And you should make every inch of this 4 weeks left over to become the winner. Thank you, and we'll all see tomorrow.